recording of the presentation, and the CEU certificate. So I think that's all that I have for now. Mickey, I'll hand it over to you.
Hi, everyone. My name is Mickey Fazio. Thanks for joining. Like Marie said, we have so much to cover. Next year, we're probably going to do this in 2 parts because it's just so much information. It seems like every year it's just more and more. So next year, we'll probably do 2 presentations on this. If I cover anything too fast, I tend to talk fast sometimes. Or if you'd like clarification, please feel free to write in a question, like Marie said, at the end of the presentation. And I will definitely make sure to answer those, and we'll have those posted within a couple of weeks on the Vitalware website. So let's get started. So here's our disclaimer statement, and this is just saying that this information was current at the time of this presentation, but we always advise that you refer to the most up-to-date resources and regulations at a later date. So here's our agenda. First, we're going to go over CM additions, deletions, and revisions, CM guideline changes, PCS additions, deletions, and revisions, PCS guideline changes, and then some MSDRG updates from our final rule. So let's start with CM code changes. Here's a summary. You can see that the number of new codes, revisions, and deletions are here. We have quite a large number of new POA exempt codes. They are mainly from Chapter 19, which is injury, poisoning, and other external causes. Chapter 20, external causes of morbidity. And then there's a few from Chapter 17, which is your congenital malformations and chromosomal abnormalities. And then you can see the MCC and CC changes here, and we're going to go over that in a bit as well. So here are your MCC additions this year, and the deletions are in this little side table, and these are mainly codes that are being deleted because they're being expanded upon this year. So the expanded codes are MCCs. Here are additions to the CC list. We have quite a bit additions to the CC list this year. And then here's your deletions to the CC list, and this is also because these have been expanded upon. All right, so now we're going to look at some additions, deletions, and revisions to the diagnosis codes for this year. Throughout the slide, you're going to see that I have MCCs and CCs marked. So at the end of the code description, I'll have a CC or MCC if it's a CC or MCC. And then I'll also have some code also notes in here that are going to be stored. And I just put those in because I thought they were important to point out. So first, we're going to start with Chapter 1, which is infectious and parasitic diseases. Subcategory B37.3 has been deleted because it's been split into 2 codes. Recurrent candidiasis or vulvovaginitis is defined as 3 to 4 episodes of symptomatic infection within 1 year. The treatment plan for the acute and the chronic is quite different, so that's why they split these out into 2 different codes. And then for Chapter 2, we just have some minor revisions in the neoplasms chapter. The words not classified are being changed to not elsewhere classified. For Chapter 3, G59.3, which is hemolytic uremic syndrome, has been expanded into 4 new codes. So this syndrome is a thrombotic microangiopathy, which causes hemolytic anemia, thrombocytopenia, and acute kidney injury. And the most common form is caused by infections. It's mainly in the GI tract caused by E. coli, but there's also a hereditary form of this syndrome. So both forms now have unique codes. And then you would use the other hemolytic uremic syndrome code for all other causes. There's multiple coding notes in this subcategory that state to code also for many other conditions. So you would want to pick up things like chronic kidney disease, infectious diseases, the specific hereditary disease that's causing the syndrome. It can even be a drug that's causing the syndrome, so you would want to pick that up as well. There's also new coding guidelines regarding this syndrome, so we're going to go over that as well. Next is new codes for von Willebrand disease, and this is an inherited bleeding disorder of the clotting mechanism, and it's caused by a low level of the von Willebrand factor that helps to make clots, or it could be that the factor is just not functioning properly. So there's 8 types of this disease, but there's only been one code for it until this year. There's 3 different types, but type 2 is divided into 4 different subtypes, as you see here. And then you'll see type 3 here. And then you have a code also note here saying that you should also code the platelet defects with this code. So D75.82 has been expanded to describe specific types of heparin-induced thrombocytopenia. This is when you have a decrease in platelet count that occurs during or shortly after exposure to heparin. So for this category, you are going to want to use an additional code for the adverse effect of the heparin. Next, there is a new code D81.82 for activated phosphoinositide 3 kinase delta syndrome. And this is a primary immune regulatory disorder defined as a combined immunodeficiency. And it results when you have a gene mutation, and it typically occurs in childhood, and it shows up as recurrent respiratory infections. So there's now a code for this. All right, for chapter 4, we have a new subcategory that has been added to E34.3 to describe short stature due to endocrine disorder. This is the most common cause for short stature. It's endocrine disorder due to low levels of growth hormone and insulin-like growth factor. So E34.32 is genetic causes of short stature, and that has been expanded to capture 4 different genetic causes of short stature. The next section is subcategory E87.2, and this has been expanded to capture acute versus chronic acidosis. So there is an excludes one note here for this subcategory that directs the coder to diabetic ketoacidosis if it's diabetic acidosis. So that code for the diabetic acidosis would not be found in this category. And the E87.20 through E87.22 include both the lactic acidosis and metabolic acidosis. For chronic metabolic acidosis, there's a code first note saying that you would need to code first the underlying condition. And then for E89.29, other acidosis, this would include respiratory acidosis that isn't specified in the documentation as acute or chronic. So if it's not specified, you could pick up this code. If it is specified as acute or chronic, then you would use the J96 category instead of this one. Okay, so next we're going to go over chapter 5, and we're going to look at vascular dementia. So ICD-10-CM classifies 3 main types of dementia: vascular dementia, dementia and other diseases classified elsewhere, and unspecified dementia. So each of these have gone through a major expansion this year. They have expanded to include severity levels and to account for the following. If you have behavioral disturbances or psychotic disturbance, mood disturbance and anxiety, agitation, psychotic disturbance, or different things like that. So first, we're going to look at category FO1, which is vascular dementia, which is caused by impaired circulation in the brain. And these are your codes for the vascular dementia. And then you can see the different severity levels listed here. FO2 that category is dementia in other diseases classified elsewhere. So there is a large list of other diseases that this can be found in at category FO2 in the tabular. So if you want to see which diseases this is typically found in, you can check out that list. And then FO3 is for unspecified dementia, and this includes major neurocognitive disorder. It does not include mild neurocognitive disorder. So if you have a mild neurocognitive disorder, this will be coded in FO6 category. We're going to go over that. So this is the rest of the unspecified dementia codes. So here are your codes for the mild neurocognitive disorder. It would fall into one of these two codes. And FO671 is actually a CC. So next, we're going to look at, still in chapter 5, we're going to look at category F10. This is substance and alcohol abuse, and this was missing an unspecified uncomplicated code, so this has been added this year. Also, unspecified in remission codes have been added to all of the alcohol and substance abuse codes. So this would be for cases where the past history of substance or alcohol abuse is not documented in the current admission, but it is documented that the patient is in remission. So you may not have details about what their past use was, but if you have that the patient's in remission, you could pick up these codes. Next, still in chapter 5, codes were added to capture prolonged grief disorder and other reactions to severe stress. So physicians may document things like complicated grief disorder, persistent complex bereavement disorder to capture the code for prolonged grief disorder. So these two codes replaced the deletion that you see here, which was other reactions to severe stress. And then here are some revisions in chapter 5. The underlined section is what has been added. And you can see they just added on that psychotic disturbance, mood disturbance, and anxiety. Chapter 6, there is an expansion of the muscular dystrophy codes to include a specific type called limb-girdle muscular dystrophy. And this is an genetically inherited condition that affects the proximal skeletal muscles of the limbs with weakness. The shoulder girdle and pelvic hip girdle are affected, making it extremely difficult for these patients to move. So one thing about the specificity here is that physicians tend to document this in different ways. So you may not see this exact wording in the documentation, but the tabular has really good guidance on inclusion terms of what you may see documented. So for example, for G71.031, autosomal dominant type, the doctor may refer to this as limb girdle MD type 1. And then for G71.033, which is due to dysferlin dysfunction, the doctor may say type 2B myopathy type 1. So if you don't look at those inclusion terms, it may get a little confusing which one you should choose. So definitely check out those inclusion terms when dealing with this condition. So these last two codes for limb-girdle muscular dystrophy are due to other gene dysfunctions. And then, of course, you have the unspecified here. So now chapter 6, the diseases of the nervous system. The next few additions regard post-infection conditions. The deleted code was post-viral fatigue syndrome. It's been expanded to some more specific codes. So the first is the code for POTS. This is a chronic autonomic nervous system disorder. It's a post-infectious syndrome which causes severe lightheadedness, tachycardia, dyspnea, headache, abdominal distension, and fatigue. And sometimes physicians will document this as the Costa syndrome. So that can be picked up. The POTS can be picked up if that's documented as such. One thing to note here, if chronic fatigue syndrome is documented and they don't specify the type, it would code to not otherwise specified or 53.82. Excuse me. And then here are some revisions in chapter 6, and they mainly are just changing dementia to neurocognitive disorder here. Chapter 7, we have no changes. Chapter 8, we have no changes. Chapter 9, diseases of the circulatory system. So the first code you see here is for angina pectoris. It's a clinical syndrome of precordial discomfort or pressure due to transient myocardial ischemia, but without infarction. So there are treatments for this, including drugs, coronary angioplasty, or bypass surgery. But when these treatments don't work, then it's called refractory angina pectoris. So the concept of refractory was previously not captured in any of the codes, but now it's captured in these new codes. And these are all CCs. Subcategory 131.3, which is pericardial effusion, non-inflammatory type. This has been expanded to include the malignant type. I have deletions of the non-specific ones that were expanded a couple slides down. You'll see that many codes were added for specific regions and anatomical detail for both aortic aneurysms and dissection of the aorta. And I just want to point out when they reference thoracoabdominal here, this means that, this is a different term, but this means that it's an aortic aneurysm that extends from above the diaphragm to below the diaphragm. It spans through both regions. So the three codes that could be used to pick up this type of aneurysm would be the 171.50, 51, and 52. And the one that's chosen really just depends on how far down into the abdominal aorta the aneurysm is. You'll notice that any code referencing a ruptured aneurysm is automatically an MCC. The others are not MCCs or CCs. So if it didn't rupture, you're not getting an MCC or a CC. And here are your deletions. Next, for chapter 10, we have a new code. And this is just adding a third code to the other two transfusion-associated complications, which are circulatory overload and acute lung injury. So if it doesn't fall into one of those, it's going to be falling into this code. And this is a transfusion-associated dyspnea. And this is a CC. Chapter 11, diseases of the digestive system. Hepatic encephalopathy has been added to separate it out from hepatic failure. One thing to note here is that there's a large list of code also notes along with some exclusion notes for this code. So make sure that you read through those before assigning. For revisions for chapter 11, they just added gangrene into those acute appendicitis codes. Chapter 12, we have no changes for this chapter. Chapter 13, in the M51 category, invertebral annulus fibrosis defects have been added, and these are defects that are developed actually during a discectomy surgery. So if the defect is large enough, it can require an additional surgery to be done to close the defect. Each of the defect codes has a code first note to code the disc herniation first. M62 is for muscle wasting and atrophy of the muscles of the spine, which plays a role in low back pain. M93, these are new codes for slipped femoral epiphysis. This happens when the head of the femur slips backward and downward at the growth plate. It can either be traumatic or non-traumatic. This year, they have only added the codes for non-traumatic. They also added subcategories for the slipped epiphysis, and they are stable and unstable. So stable is when the patient cannot bear any weight on it, and then stable is when the patient can bear weight on it, and then unstable is when the patient cannot bear weight. The last code changes are related to fractures that are associated with chest compressions for CPR, way at the bottom here. And then here are the revisions for chapter 13. They just added the word stable onto these non-traumatic femoral epiphysis codes. Chapter 14, for the N14 category, the first two codes that you see listed here, these are renal conditions that are caused by drugs or heavy metals. And there's a code first note here that you should code the first you should code the poisoning due to the drug or toxin and use an additional code to specify the adverse effect from the drug. The next code is for Fournier disease, this N76.82. Fournier disease is an acute severe infectious gangrene of the perineum. This is not a form of diabetic gangrene. So if the patient also has diabetes, you should assign a code for diabetes with 0.9 as your fourth character here. If they truly have documentation of diabetic gangrene and not Fournier disease, then you would code the diabetes with the fourth and fifth characters of 0.52 for gangrene in diabetes. If you need more information on this, refer to Coding Clinic second quarter 2020, page 18, and it has more details on how to decipher between the two. The rest of the codes in this section specify various different areas where endometriosis can occur, specific details about the depth, the side, every kind of detail you could want to know about endometriosis. I didn't include all of the codes because there's so many of them. The number of codes in this category increased to 136. And so I just included a summary of the codes here. The last code here, N85.A, is for ismosil, and this is for a non-pregnant patient only, and you should also code any associated conditions with this code. All right, in the pregnancy childbirth chapter 15, we have many new codes added here. This chart shows the new subcategories within the chapter. And I have deletions coming up on the next slide. I didn't include all of the codes here because, again, it was a large number. So this just shows you like a breakdown of where new codes were added. And then here are the deletions. All right, chapter 16, we have new codes that were added for various types of newborn apnea in this chapter, and they are all CCs. And then your deletions are just because they were expanded into more specific types. Chapter 17, category Q21 is for various types of atrial septal defects, which is a hole in one or both of the walls between the left and right chambers of the heart. All of these new codes describing various types of septal defects are CCs. Next, the codes in category Q85. These are new codes for diagnoses referred to as phacomatoses. This term is used for a group of rare syndromes that's characterized by vascular and pigmentary birthmarks or skin lesions on the body. And these are also CCs. Chapter 18, we have no changes. Chapter 19, we have 3 major changes in category SO6, which is intracranial injuries. The first major change is primary blast injury, and this is a brain injury in which a pressure wave passes through the body and the head, inducing primary tissue damage to the brain, which causes cerebral edema, prolonged cerebral vasospasms, and blood-brain barrier dysfunction. The other 2 changes are just regarding loss of consciousness. The next additions in this chapter are for methamphetamines, and they have been given their own subcategories. So revised from being in category T43.62, they're now in T43.65. I didn't list out all of these codes because there's so many, but the codes listed here would need an additional 7th character to be complete. And a character of A would be your initial encounter, D would be a subsequent encounter, and then S would be a sequela. So each of these codes have 3 different options that they could have. All right, and then chapter 20, external causes of morbidity. So we have this year hundreds of codes for injuries involving electric bikes. So that was pretty crazy to me. They must be seeing that a lot in the ER or something. But so categories V20 through V29. And currently these categories involve motorcycles, not bikes, but the motorcycle codes have actually been deleted and replaced with the term electric bike. So I didn't include all the additions here because, like I said, there's hundreds. But there's also alternative names for electric bikes. So if you see in the documentation, electric assisted bikes, e-bikes, hybrid bikes, that all falls into this category. The next change is for code W23.2 category, and this has been added to allow for coding of the unique situation when an injury involves a moving object and a stationary object. So if you're caught or crushed between one moving object and one stationary object. For chapter 21, most of these Z codes are pretty self-explanatory, so I'm not going to go over all of them in the interest of time, but if you have any questions, like I said, please submit them at the end of the presentation. And here's the deletions to this chapter. Okay, so now we're going to go over some CM guidelines. And anything in blue and underline has been added this year. So this first one is regarding documentation by a clinician or other than a provider. So we know that most of the time we can't code documentation taken from a nurse, therapist, or case manager or other clinician, but there are certain situations where you can code off of their documentation, and this list tells you when it's okay. They added in under immunization status to this list. This next guideline update regards complications of care. We know that a physician must document when something is considered a complication of care or a complication of a procedure, unless it's otherwise specified in the classification. Here they're just clarifying that the physician's documentation must support that the complication is clinically significant and that the physician doesn't necessarily have to document the word complication. They give the example that if during the course of surgery, the surgery is altered due to something that happened during the procedure, it would be appropriate to code a complication code here, even if the physician doesn't necessarily say this was a complication of the surgery. This next one is regarding the sequencing of codes when a patient has an HIV-related condition. Typically, HIV would be your principal diagnosis, followed by the HIV-related condition. However, here they're stating that if the associated condition is hemolytic uremic syndrome associated with HIV, then you would use the code D59.31 infection-associated hemolytic uremic syndrome as your primary, and then the HIV code would be sequenced second. Same thing here with hemolytic uremic syndrome when it's associated with sepsis. You would code the D59.31 as your principal, and then the next code would be your sepsis codes. This next guideline changed to neoplasm chapter. This is just adding clarifying language stating that if a malignancy is responsible for admission and is treated, then the primary malignancy should be your principal. But the only exception to this is if the primary reason for admission would be chemoimmunotherapy or radiation therapy. Next guideline change is just saying that when you have a malignant neoplasm of lymphoid tissue and it spreads to another organ, you would not code a secondary neoplasm of the affected solid organ. You would use a code from categories C81 through 85 with a final character of 9 to identify extranodal and solid organ sites. This next guideline is regarding dementia. The codes for dementia are assigned based on severity, but the doctor must document the severity in order for you to capture it. So otherwise you would code it to the unspecified code. Also, if it's an inpatient admission and the dementia progresses to a higher severity level during the stay, you would only want to capture the highest severity level in your coding. Excuse me. This next update is regarding completed weeks of gestation. And in the classification, completed weeks means full weeks. So if the patient is 39 weeks and 6 days, the code for 39 weeks would be used, not the one for 40 weeks, because they have not yet reached 40 weeks. This next one is just telling you how to appropriately code a situation where a patient has an elective abortion with a hemorrhage. So code 004.6, delayed or excessive hemorrhage following induced termination of pregnancy, should be used. You should not use codes 072.1, which is other immediate postpartum hemorrhage, or Z33.2, which is encounter for elective termination of pregnancy when the patient experiences a complication post-elective abortion. This next guideline is regarding underdosing. You do not need documentation of a change in the patient's condition in order to capture an underdosing code. You only need documentation that the patient is not taking the medication as they were prescribed. Next guideline refers to social determinants of health, and this is just clarifying that social determinants of health codes should only be assigned if the patient is experiencing an associated problem. So not everyone who lives alone would be assigned a code for problems related to living alone. It would only be if that is presenting a problem for the patient. All right, moving on to PCS changes. This year's update includes more additions and deletions in the new technology section than in all of the other sections. And we are going to review the additions first, and then I'll have the deletions at the end. I wasn't able to list out all of the codes in some areas due to the large volume. So I do have a link here that you can click to find the code changes, the table to all of the code changes. So first we're going to talk about laser interstitial thermotherapy. We're going to go into the PCS tables in upcoming slides, but I wanted to cover changes regarding lit therapy first because this was where most of the changes to the PCS codes regarding this procedure were this year, and it affects multiple chapters. So we're going to go over this first. So lit is ablation, necrosis, or coagulation of soft tissue using thermotherapy or heat from a laser. In the past, the lit codes were incorrectly classified. So they were classified to the radiation therapy section, and they're really not radiation therapy because there's no ionizing radiation involved during lit therapy. So these are being moved throughout the chapters to the chapters they belong in. Also, just a note on the slides, the upcoming slides, I have included the manufacturers on most of the procedures just because I feel like the manufacturers' websites have really good videos, they have really good information. Sometimes they even have coding information on how to code the procedure. So first we're going to talk about the extraction of the central nervous system and cranial nerves. And body part value C, cerebellum, has been added. CUSA, which is the Cavitron ultrasonic surgical aspiration, is used to fragment and aspirate tumor tissue and organs, including the brain. Next, we're going to talk about insertion into the nervous system. So two new technology neurostimulator leads have been added to this table, the sphenopalatine ganglion and the vagus nerve. And these are both used to treat ischemic stroke. They provide stimulation to different parts of the nervous system that help to aid in the rehab of the stroke. So the first code describes the insertion of the sphenopalatine ganglion neurostimulator lead. This is a percutaneous procedure that's actually done through the mouth, and the transmitter for the lead is external, and it's applied only during the treatment session. The next code describes the insertion of the vagus nerve neurostimulator lead, and this one is placed percutaneously, and the stimulator is placed in the normal manner. This device is paired with therapy to create new neural pathways. And we have a code also note listed here that you need to pick up the insertion of the stimulator generator into the chest subcutaneous tissue whenever you assign this code. The next table is for other procedures of the nervous system, and there were added to the device substance and technology. Value 1 has been added, which is computer assisted transcranial magnetic stimulation. And you can see the new code here. TMS is performed to stimulate the prefrontal cortex of the brain in patients with refractory major depressive disorder. The Magnus neuromodulation system combines electromagnetic therapy with MRI images that target the most appropriate location that they should stimulate. So next, table is for assistance of the cardiovascular system, and a new device substance technology value of 5, intermittent coronary sinus occlusion, was added. And the system that's used here is the PCS system. This is pressure controlled intermittent coronary sinus occlusion that is performed using the PCS system. And this procedure assists the heart following a percutaneous coronary intervention for an MI. I included a video here that really shows good detail about how the procedure is done. So check that out when you have a minute. Next is occlusion of the lower arteries, and there's addition of qualifiers V and W, which is the prostatic arteries, and occlusion of the prostatic artery via the internal iliac artery is similar to in women when you have an occlusion of the uterine artery for embolization of fibroids. So when the prostatic artery is occluded, it reduces the size of the prostate, and that treats benign prostatic hypertrophy. So the prostatic artery is a branch of the internal iliac artery in males, just as the uterine artery is a branch of the internal iliac in females. These qualifiers were added so that the coding of the procedure just makes sense with the diagnosis of the benign prostatic hypertrophy. The next slide has all of the added codes. Here they are. This table is for transfer into the gastrointestinal system. And we have some new qualifiers here to describe transfer destinations: bladder, the ureters, either right, left, or bilateral, the large intestine, the small intestine, and one or both ureters can be transferred to the bladder. What they mean when they say transfer is that they're keeping the blood supply going to that body part and connecting it to another body part. So I have a good little picture here that kind of shows this is the intestine. And so, for example, if they take the small intestine and they cut a piece of it, but they keep the blood flowing to it, and then they connect that piece to the bladder. So your qualifier here is where you are connecting that body part to. And here's the rest of those codes. Next table is for destruction of the hepatobiliary system or in pancreas, and new device substance technology value of 0, ultrasound guided cavitation, has been added. This is a new histotripsy procedure. Histosonics is the manufacturer, and they have developed a new non-thermal and non-ionizing radiation method for destruction of cells. It uses acoustic cavitation with imaging guidance. So the system creates a bubble cloud that rapidly expands and collapses to mechanically destroy the targeted tissue. And this is typically used for the destruction of liver cancer. Next is the removal of head and facial bones table, and these codes are specifically for the Ommaya reservoir. This can be placed for intrathecal chemotherapy administration. The insertion code for the skull was added last year, and this year they added the removal and revision codes, as well as more approaches. So here are the removal codes, and then here are your revision codes. Next table is for supplement of the muscles, tendons, bursae, and ligaments. And you can see the two new codes here. And Ligapass 2.0, posterior vertebral tether, is a braided polyethylene band that loops through the spinous process of the posterior vertebrae. The tether reinforces the upper or lower spine ligaments. Just want you to note here that this is not the same as vertebral body tethering, because vertebral body tethering happens on the anterior part of the vertebrae, and that's used to treat scoliosis. This tether is threaded on the posterior spinal fusion. It's added to a spinal fusion that has already occurred, or they could do the spinal fusion and then put the tether in. So it uses the existing rods. And it's used to help treat or prevent kyphosis. Stopping this movement, what it does is stops the movement, and it helps the fusion stay stable and helps to reduce the pain. So we now have two codes available for this. The next is insertion into the joints. And this is specifically for the top system from Premia Spine. This is an implant that treats spinal stenosis and neurogenic claudication without creating a fusion mass. So it's an alternative to lumbar spinal fusion. Top stabilizes the spine and allows controlled movements in all directions. And I included a video here because it's really cool. It really allows more movement in the spine than your typical fusion does. So it's really a good option. So check that video out if you have a chance. Next, we have insertion into the bones, and a new device substance technology value of 5 was added here for internal fixation device with a tulip connector. This is an internal fixation device that's either used to stabilize the spine to the pelvic bone or to fuse the sacroiliac joint. The device can be used with either a current or prior fusion of the lumbar spine. So the decision of which table to use, we have this table and then we have a table on the next slide. The decision of which table to use really depends on where you're going to be inserting the device. So one thing to note here is that these codes have to be used with the Bedrock Granite device. So if you're not using that particular device, these codes are not the codes you want to be using. So the table here shows if you are inserting the Granite device in the pelvic bone. And then this table is if you are inserting into the sacroiliac joint. Next is replacement of joints. And these new codes are for the replacement of lateral or medial meniscus with a synthetic substitute. New surface makes this meniscus replacement excuse me, prosthesis, and it's made from medical grade plastic and is made to where it can remain in place and not need to be permanently attached. So this allows for it to move and function like a normal meniscus. I've included a really good video here that actually shows how they insert it and what it looks like. Next, for drainage of the general anatomical region, approaches for natural and artificial opening and endoscopic natural and artificial opening have been added, and body part 6, which is neck, has been added to code the drainage of a retropharyngeal or parapharyngeal abscess using a scope. This is a deep space abscess in the neck. Next is the introduction into the physiological systems and anatomical regions. We have new approach values here, new body part values, and new qualifier values. And these new additions allow for coding of the subchondroplasty procedure using AcuFeel into bone voids in subchondral bone. This is only part of the table included here because the table is extremely large. Next, we have introduction into physiological systems and anatomical regions. This is for monoclonal antibodies. This is just being moved from the new technology table to the administration table. And then same thing here. These are codes that are being moved from the new technology table into the medical surgical replacement table. Next is assistance with cardiac perfusion with supersaturated oxygen. This is done following an MI and a coronary intervention in the left anterior descending artery. We used to report this with 2 other codes that were for intermittent versus continuous, but they have found that this is always going to be continuous, so they just have 1 code now for it. Next is for imaging in the respiratory system. This is very different. So this type of imaging is when they the patient inhales this type of gas and they hold their breath for 10 to 15 seconds, and it gets a really good picture of the air in the lungs that can be visualized on an MRI. So this table for new technology measurement, we have some additions this year, have them listed right here, and we're going to go further into them. So for this one, this is the SeptiSite Rapid. This differentiates between an infection-positive sepsis and a non-infection system inflammation, which is very important. This test actually measures the mRNA in white blood cells. It's at a 1-hour turnaround time, and it should be documented in your sepsis bundle orders or your lab results or the progress notes. But yes, so this is good technology. The next one is for the Nelly seizure monitoring system. And this is an automated analysis of audio and video data to identify seizure events in children and adults. And it uses AI intelligence as an add-on to standard EEG monitoring. It can run for 24 hours up to 28 days to detect any seizures. The next addition to this table is for quantitative flow ratio. This is a non-invasive analysis of flow velocity through the coronary arteries without the use of a pressure wire or vasodilator. It uses mathematical modeling to determine if a vessel needs treatment. I included this image because this is actually what the image looks like when they do this test. And the last one here is for the precision TAVI valve modeling. This is used for pre-planning for a TAVR, which is an aortic valve replacement. It works with CT angiogram images and calculates the risk biomarker. The physician then receives a report and a 3D simulation image of the exact locations of which coronary arteries need to be treated within the aortic route. And then next, we have many new codes that were added to the substance technology table for 2023. On the next slide, I'll show you the new codes, and we'll briefly talk about a couple specific ones. So the two highlighted ones are the ones we're going to talk about. This first code is for rhythmic, is the name of the substance, and it's used when with the absence of a thymus. It's surgically introduced into the thigh muscle of the patient, and it helps produce immunocompetent T cells for the patient. And then the second code highlighted here is for fecal microbiota transplant. And this helps restore beneficial microbes that were killed whenever they treated a C. diff infection. And the administration of this substance should be documented in an operative report, as this is a longer procedure and the administration is through the anus. So here are some transfusion codes, and these are for treatments that are called ex vivo technology, which means they're outside the body. So it takes the patient's cells, modifies them, and then returns them to the body. Here is a new code for DefenCath, which is used to help prevent catheter-related bloodstream infections associated with hemodialysis performed through a central line. So this is used in place of regular heparin locking solution at the completion of the therapy and is aspirated at the beginning of the next session. Here are the deleted PCS codes this year with potential replacement codes. So it's quite a bit of them. And if you're looking for a code to replace it, you have your potential replacement codes here. And now we're going to look at guideline changes. So this guideline doesn't really contain any new information. It just simply brings us information from from past coding clinics and it's now bringing it into guideline form. So it's regarding the site of the detachment for detachment procedures on extremities. And then this is the second part of guideline B3.19. It is used as a reference chart for the definitions used for detachment qualifiers on amputation. So it's a good reference when doing an amputation. This next guideline has been debated because it was not clear if it applied to other body systems or only vascular procedures. So here it's been updated to clarify that this guideline only applies to vascular system and specifically to the arteries and veins of the body. The next guideline has been updated to indicate that a complication with a device that requires removal after placement in the same operative session must be documented as a complication by the provider. This is now a scenario in which you may need a query if it's not documented as a complication. So we have several MS-DRG changes this year from the Federal Registry, the final rule. I always like to go over this first. If you are someone who works at a facility with case mix index for your facility, a good way to see if there's any major impacts every year to your case mix index that may be coming is to look at this table I have linked here. This is table 5 on the CMS website. Identify your top 20 MS-DRGs by volume at your facility, because those are the ones that's going to make the biggest impact. And then compare the relative weights on those particular DRGs between the year you're currently in and the upcoming year. And that will kind of highlight where you may see an impact. And that's useful information for, revenue cycle leadership about upcoming changes to case mix index. So some DRG changes. This is regarding T-cell and other immunotherapy therapies. This year, they added other immunotherapies to this pre-MDC. So it's not just T-cells. These codes listed here will now be classified as non-OR procedures. So I'm just trying to gauge my time here. All right, let's see. I'm not going to read all of these because this is very self-explanatory. You can read this, but in these next few slides, I'm really just telling you when procedures or principal diagnosis codes will be moved from one DRG to another. Since lit codes were moved from radiation therapy section to the medical surgical body systems, they have moved to new DRGs. And then we have 24 PCS codes describing the insertion of a stimulator generator that were added to the other vascular procedure DRGs. We have 108 PCS code clusters describing the insertion of a stimulator generator that's not differentiated by device type that moved to peripheral cranial nerve and other nervous system procedures. Here we have J80, which is for ORDS, or acute respiratory distress syndrome. These have been moved from respiratory signs and symptoms to the respiratory failure DRG, because it's a more serious condition. MDC-05, diseases of the cardiovascular system. So the procedure code for supplement of mitral valve has been moved from coronary bypass to endovascular cardiac valve replacement procedures. This MDC-05, which is the circulatory system diseases, barostim neosystem procedures with a principal diagnosis of post-procedural heart failure were moved from, they're now going to group to cardiac defibrillator implant with cardiac catheterization. PCS code MAP conduction mechanism open approach is moving from percutaneous cardiovascular procedures with drug-eluting stent to percutaneous and other intracardiac procedures. And then PCS code for extirpation of matter from the common bile duct is now changed to an OR procedure, and that will be moved to cholecystectomy DRGs. So that will probably be increased reimbursement for you. MDC-15 for newborns, basically any codes having to do with exposure or contact with a suspected infectious condition will now be moved to DRG for a normal newborn. And then let's see. So procedure codes for embolization of portal or hepatic veins, they're now being moved from the extensive OR procedure unrelated to principal diagnosis. They're now being moved to more appropriately other hepatobiliary or pancreas procedures. Excision of hip muscle, which is the biopsy codes. These are being moved into a new DRG from the OR procedures that are unrelated to principal diagnosis. They're being moved to the major GI disorders. Just to note, these biopsies are no longer considered an OR procedure. All right, I got through it all. Can't believe. So I just want to take a moment for any new viewers to introduce Vitalware by Health Catalyst. We offer products to assist you with your revenue cycle processes. We are awarded first in class for our Charge Master product 4 years in a row. So come check us out at vitalware.com for more information. And here are resources. Please check out these resources, really good information. Also, the videos that are included in the presentation, those are super helpful for really understanding the procedure. And that is it.
Awesome. I think if you want to take,
yeah, we may have time for a couple questions.
Yeah, if you want to answer a couple, go ahead and we can wrap up.
All right, let's see. So the first one says, do you have any details on the clinical validation criteria needed to support coding acute versus chronic metabolic acidosis? I do not, off the top of my head, have that criteria, but I will definitely include that in my Q&A document for you. That's going to be posted on the Vitalware website within 2 weeks. Let's see. Lots of comments in the question and answer section. Let's see. Are y'all going to send out the PowerPoint? Yes. Okay. Is hepatic encephalopathy an MCC? Let's see. Let me check for you. Let's see. That should be in the presentation. Let's see. I have to go back to the beginning. That should be included in that table that was at the beginning. Sorry guys for like going through this really fast, but it should be in that table that was at the beginning of the presentation with all the new MCCs. Let's see.
Just while you're finding that, I can take a couple of the other questions and reminders. So a few people are asking, how do we obtain the CEUs? Those will be sent to everyone by end of day tomorrow. And if for some reason you do not receive them, you can just reach out to us and we can get those to you. Same thing with the slide deck and recording. A link to those will also be provided if you don't already have it. So I think that about covers it.
I don't see it in the MCC list, but it may be on the CC list. The CC list is a lot bigger. But I'm definitely going to clarify that on the question and answer document. I will double check the MCC list just to make sure. And that is it. We didn't have many questions.
Okay, awesome. Well, I think we covered everything then. Thank you so much for joining us today, everyone. And just one more note, we will have, I think 8 other webinars for year end, some coding updates and stuff like that. So just keep checking our website. We'll have those posted soon. I think our next ones are beginning of November. So look out for those and have a great rest of your day. Thank you.
All right, thanks.